Welcome to the part one of the lecture on organ transplant science. This part of the presentation will focus on the science, statistics, laws and regulations, medical aspects, including challenges, treatment, complications, and future considerations in organ transplantation. Part two will focus on the rehabilitation aspects. I recommend you play this YouTube video at 1.5 or 1.75 times for optimal speed. Let's get started. These are the objectives of part one of this presentation. Rehabilitation science objectives will be in part two. Let's look at what exactly we mean by organ transplants and their types. Organ transplant is the process of removing and moving an organ from a donor to a host. This is a complex process and there are many challenges. Procurement challenges include donor availability and availability of matched organs and how to equitably allocate organs to the needy. Do we go by the sickest patient waiting for an organ? Or should allocation be done by the proximity to the donor, where length of time is crucial for organ viability? Of course, there are many other challenges in procurement alone. On the other hand, a big challenge is how to control the response of the host immune system to a foreign antigen of the donor organ. We will study this in more details in this presentation. What are the indications for organ transplantations? Organ transplantations can be done for two reasons. It's either a life or limb-saving process, or it is done for research purposes. There are three major reasons for organ transplantations. The organ must be failing and be at its end stage. That is end stage organ failure. So organ failures such as heart or kidneys, when they reach this end stage, that means it's no longer possible to keep the organ going even with external support, and therefore it needs a transplant. Similarly, irreversibly damaged organs, for example, an organ like the liver, in case of cirrhosis, it is irreversibly damaged and needs to be replaced. And then we have organs that are performing abnormally to the point that it is no longer doing what it is supposed to do. And so that would need replacement. Now, there are other indications for transplantations. For example, if a limb is severed and then it needs to be put back, or for that matter, a limb from another person is put onto a host, that type of organ transplantation is also transplantation, and therefore that is a different type of transplant. Potential organ donors need to satisfy many different criteria. However, certain general criteria apply to everybody. In terms of age, donors must be less than 50 years ideally. However, an extended case or pool of up to 60-year-old donors have been used. Donors must be disease-free. There should be no evidence of history of cancer, present or past. There should be no history of any infectious disease such as HIV, hepatitis, and sepsis. There should be none of the contraindicated illness or disease, especially for the particular organ type being considered for transplantation. For example, for liver transplantation, there should be no history of cirrhosis of the liver. For lung and heart transplants, there should be no history of pulmonary hypertension other pulmonary diseases, or heart failure. Weight is a criteria. Donors must be within 20% of their ideal BMI. However, in recent times, this criteria has been relatively relaxed and donors of over 35 BMI have been accepted. If it is a heart transplant case, the donor's left ventricular ejection fraction must be over 40%. Transplants may be solid or liquid. Solid transplants may be structural transplants, whole transplants, or partial transplants. Examples of each are provided. Structural transplants can be like skin grafting. The heart, lungs, and kidneys have to be transplanted whole. Organs such as the liver can be transplanted as partial. Here are some examples of whole organ transplants. They include, among others, heart, lungs, kidneys, and more recently, vascularized composite allotransplantation, or VCA. Now, VCA is a continuously evolving area of modern transplant medicine. Recently, though, the VCAs have been formally classified as organs. Previously, they used to be classified as tissues. So, what is VCA? VCA refers to the transfer of a vascularized human body part containing multiple tissue types, such as skin, muscle, bone, nerves, and blood vessels, together as a unit or as an anatomical or structural unit from a human donor to a human recipient. The first reported unilateral hand transplantation was performed in Ecuador in 1963, but the transplant had to be removed within 2 weeks due to acute rejection. The first successful hand transplantation after the introduction of cyclosporin followed the Ecuador surgery by 35 years in 1998 in France. Cyclosporin is a drug that suppresses the immune response and thus decreases the rejection phenomena. In 2005, the first face transplantation was performed in Lyon, also in France. Face transplantation cases have evolved since then and have been highly publicized in medicine and in the media. This is a special category of transplants localized at the border between tissue and organ transplantation. Human cells and tissues for transplantation can save lives or restore essential functions. For example, a corneal graft can restore sight in corneal blindness. The transplantation of hematopoietic stem cells can cure congenital or acquired diseases, including some leukemias. Hematopoietic stem cells can be collected from living donors, either as bone marrow or from peripheral blood. Additionally, they may be collected as cord blood drawn from the placenta during or after delivery. See further information on hematopoietic stem cells in the section titled Liquid Transplants, and that is linked from slide number 13. The transplantation of a human heart valve often constitutes the best replacement situation for defective heart valves, and the recipient patients do not require long-term anticoagulation therapy. The ethics of procurement for living donors include the provision of the knowledge of the intended use of the tissues and the process that they are donating. As far as health concerns of tissue transplants are concerned, human cells and tissues for transplantation represents a special class of basic essential healthcare products, as well as being the potential starting material for much more complex biotechnology products in the future. As with all transplanted material of human origin, they do carry risks of disease transmission, which must be controlled by the application of stringent donor selection criteria and comprehensive quality systems. Sometimes organs are transplanted in combination. These combined transplants are often done because there is not only failure of more than one organ, but because these organs are very interdependent for their functioning within the body. So sometimes these organs are transplanted in multiples. When there are multiple organs involved, they are known as cluster operations, and they are usually done in pediatrics. Unlike solid transplants that we have discussed, certain tissue transplants are liquid in nature. These are hematogenous products, that is, they are derived from the blood. More information is available from the liquid transplant section that is linked from this slide. Read the instructions how to navigate on this slide. Essentially, there are two types of donors. Either it is a deceased donor who is obviously dead, or it is a living donor. Traditionally, donors have been deceased donors. That means organs could only have been harvested from patients who have passed. However, there is an increasing trend towards getting organs from living donors. As can be expected, not every donation organ can be from a living donor. For example, heart cannot be donated by a living person. Therefore, the trend of living donors only extends to certain organs. A potential donor can sign up for organ donation by two simple processes. Any one of the two can be used. Either sign up online, or one can sign up at the local Department of Motor Vehicles, the DMV. This process is for deceased donation. That means donation after death. However, the process of living donors is slightly different. The links take you to appropriate web pages where you can get more information on this. The writer and philosopher George Santayana said, "Those who cannot remember the past are condemned to repeat it." Before we got to the present, one needs to have a brief understanding of how we got here. This section has 4 slides that discuss a brief history of transplantation science. I will keep narration to a minimum and let you read through these 4. The earliest history in organ transplantation actually comes from the ancient world. It has been documented in the Sushruta Samhita, which is one of the most important ancient medical texts to survive from the ancient world. It is a treatise on medicine and surgery, and it deals with foundations of surgery that includes organ transplantations and plastic surgery. Modern progress in the field of organ transplantation means that today's patients now survive to 25 plus years beyond the procedure. Uh, In 2004, we celebrated the 50th anniversary of the first organs ever transplanted, and that was the kidneys. There has been much progress in recent times in the field of liver, heart, and pancreas transplants, and it started in the 1960s. This slide shows you some major events on a timeline in transplant history. The earliest challenges in complex organ transplants were how to suture blood vessels of the organs and the blood vessels of the recipient together. The work on this by Dr. Alexis Carrel got the 1912 Nobel in Physiology and Medicine. The other great challenge in transplant science is that of immune rejection and immune tolerance. The next several major advances in transplantation science involves the work in this area. There are links on the slide and the next, and if you are using your PDF version, do take a moment to read about these major scientific advances and the people who brought it about. So let's look at trends in organ transplants in the United States. In studying data, here are some sobering considerations. Every 10 minutes, a new candidate is registered on the U.S. national waiting list. About 20 people will die each day while waiting for a transplant. You may be one of the professionals caring for these individuals. A single donor can save up to 8 lives. The following 3 slides show you 3 important data sets. The first one is for waiting list candidates. The second one is on transplants completed by organ type. And the third one is on transplants done by donor type based on data from 2018. This data is updated daily on the website of the organization that regulates all organ donation in the US. You can pause the video to get a preliminary look at the following 3 slides or refer to your PDF version. More information about the regulatory organization will be discussed in the Laws and Regulations section. From an epidemiologic perspective, there is an acute worldwide shortage of organs for transplant. The demand outstrips the supply by a vast margin. Of the people who die per year, many are potentially appropriate organ donors who never end up donating. A 2005 data shows that out of 12,000 to 15,000 potential donors, only about 7,500 people actually donated their organs. Some considerations about organ transplants that you should keep in mind is because of the supply and demand mismatch, transplant candidates routinely wait for years before they might get a transplant. Living donation, that is the donation of an organ while the donor is still alive, is not always a possibility. For example, you can't have a heart donation or a lung donation while the person who is the donor is still alive. More than 40% of patients wait 2 years or more for most major organ types that are waitlisted in the US. Some other statistics involves that 0.5% of the patients become medically unsuitable by the time that the organ might become available for them, and therefore they are removed from the wait list. 2% of patients refuse transplant after being waitlisted forever, and 10 to 18% of the patients will die while still on the waiting list. An allocation system is necessary in any system where the supply and demand are not balanced. Allocation system has to be fair and equitable. The criteria and policies that matches deceased donor organs with patients on the waiting list are different for each organ type. For example, the National Liver Allocation Policy is developed with extensive input from the public and the community of donation and transplantation professionals. Improving technology over time has allowed improvements in supply and demand. Currently, we can harvest up to 25 organs per cadaveric donor. That can help up to 50 recipients. Additionally, changes in laws and regulations combined with technology and understanding of medical sciences has allowed gradual increase in living donors. In this section, we will get an introductory insight into the laws and organizations that regulate organ transplantation in the United States. Prior to 1984, there was no formal procedure for coordinating the complex mechanism of coordinating between donors and recipients for organ transplantation. Under the administration of the then President Ronald Reagan, a call was made for creating a comprehensive framework for the development and administration of a national transplant database or registry. The law that governed this would come to be known as the National Organ Transplant Act, or NOTA. Based on NOTA, a registry was established. This registry would coordinate all donors and recipients, and it was named the Organ Procurement and Transplant Network, OPTN. A request was made by the Department of Health and Human Services for an organization to put forth proposals to administer this registry, or OPTN. In 1986, one such organization was selected out of many, and they were awarded the contract for operating the registry, the OPTN registry. This final ruling from Department of Home and Health Services was awarded to the company called United Network for Organ Sharing, or UNOS. UNOS continued its operations until 2004, when, for the first time, the criteria for donation processes were improved to allow live donation processes. While UNOS continues to administer OPTN, it now does so under the original NOTA Act and also the improvement that was done in 2004. That improvement was named the Organ Donation and Recovery Improvement Act, or ODRIA. These are the framework of the laws under which UNOS and OPTN now continue their operations. In a nutshell, the UNOS organization is a mission-driven, non-profit organization that brings together the donor and the transplant community. It establishes a transplant system that is fair, objective, and consistent for every patient on the waiting list. UNOS is tasked with the administration of the registry called OPTN. Find more information about the organization and the registry at the given links. Let us look at UNET. UNET is the electronic platform designed, built, continuously updated, and maintained by an organization by the name of UNOS over the course of 30 years for fulfilling requirements of what is known as the OPTN contract that we will shortly talk about. A UNET is a centralized computerized network that links all 58 organ procurement organizations, 254 transplant hospitals, and 150 histocompatibility labs. Thousands of transplant professionals access this secure web-based transplant platform each day to list patients for transplant, match patients with available donor organs, and submit required data to OPTN, which is the contract that I will shortly talk about. So the organization UNOS developed the UNET system or database to enable members to submit, store, manage, and display the organ procurement data using a secure, efficient, reliable, and web-accessible platform. So the UNET platform includes several databases. One is called Waitlist. Waitlist assists the transplant hospitals to manage information about their patients in need of transplant and uses a series of complex algorithms to calculate a patient's medical urgency and predicted transplant benefit. Another database within the UNET database is the DonorNet. DonorNet provides the organ procurement organizations the ability to add and modify donor data, execute match runs, make electronic organ offers, and supplement the donor record with related medical information and source documents. Transplant hospitals view and record organ acceptance and refusal decisions on all organ offers. So these are some of the important databases that work within UNET. Again, UNET is an online database system run in the United States by an organization known as UNOS. Every organ donation that has been done since October 1st of 1987 is run off of the UNET database. It is used for all these different functions that I mentioned and is listed on your screen. In case of OPTN, it is the National Transplant Network, which was established by federal law, as I have already discussed. Currently, every transplant hospital, organ procurement organization, and transplant community laboratories in the United States is a OPTN member. Member institutions meet the requirements of the OPTN and are responsible in forming the policies that govern the community of transplant. To coordinate donors and recipients, UNOS divides the United States into 11 geographic locations. These geographic locations work together to bring transplant professionals and other administrators to facilitate these activities. Learn more about this at this interactive map, which is available at the link which is provided at the bottom. The 11 zonal divisions of the United States by UNOS is shown on this slide. If you see, Region 2 contains West Virginia as well, which also includes Delaware, District of Columbia, Maryland, New Jersey, Pennsylvania, and Northern Virginia. You can see the other states and find your own state in here. Let's look a little bit more into organ procurement and allocation. As I have mentioned before, there is criteria for suitability of transplant, and it differs for each organ type. There are newer methods that are being constantly developed and constantly being researched as to how organs can be harvested and transplanted. On this slide, find some of the important testing criteria and the team members that are involved in the transplant process. So blood work is essential, and there are different types of tests available, as is shown in this slide or in this table. You can see that consultations are obtained from different specialists. That includes physical therapists, as you can see right here, and so on. Many factors are used to match organs with patients who all need the same organs. However, the system must accommodate some unique differences for each organ type. Organ allocation is based on a complex algorithm. Geography certainly plays a part. There are 58 local donor service areas and 11 regions that are used by the U.S. organ allocation system. Hearts and lungs have less time to be transplanted, so a radius from the donor hospital is used instead of regions when allocating those organs. The size of the organ is an important consideration. It is critical to a successful transplant, which means that children often respond better to child-sized organs. Although pediatric candidates have their own unique scoring system, children essentially are first in line for other children's organs. There are several other factors in organ allocation. Blood type and other medical factors weigh into the allocation of every donated organ. But some other factors are unique to each organ type. For the kidneys, the amount of waiting time, donor-recipient immune system incompatibility, pediatric status, prior living donor status, and how far from the donor hospital is the patient are factors that are considered. Additionally, survival benefit has been taken into account since 2015, which means how long will this person survive if they get the donated organ. In case of the heart, the criteria are medical need, how far is the patient from the donor hospital. In case of the lungs, a primary consideration is survival benefit. If a person gets a set of lungs, how long will they survive? What is the medical urgency for that patient? What is the waiting time? How long have they been waiting? What is the distance from the donor hospital? In case of the liver, the criteria are medical need, distance from donor hospital, the length of time that the organ can be preserved, and in determining that, we have to take into account the knowledge that donated organs require special methods of preservation to keep them viable between the time of procurement and the transportation. These are some common maximum organ preservation times. The hearts and lungs typically survive less time, where the kidneys can survive up to 36 hours when properly packaged. Let's look at the transplant process in one slide. Uh, ID and evaluation of donor. The OPTN is contacted through UNOS. A confirmation of brain death of the donor is verified. Consent from family is arranged. The donor at this point is being clinically managed to keep the organ viable. Once transplant surgeons become available, harvesting of the organ is done, and it is preserved and packaged for transplant. Transport is arranged, and eventually the organ reaches the transplant hospital where the recipient is, and the transplant process is done. There are major bioethical considerations in the process of donation. Let's look at some of them. There are many major bioethical issues tied to the subject of organ procurement. Let's consider a few of them. Let's begin with considering DCD versus DBD. DCD stands for donation after cardiac death versus DBD, which stands for donation after brain death. It's been a big challenge to define what constitutes death. Now, brain death is when there is no more brain waves discernible as evaluated by two independent neurologists. However, the concept of brain death is relatively newer. Prior to that, all donations were considered after cardiac death or DCD. A cardiac death is when the heart stops beating. Organs such as the heart must be optimally harvested while still beating so that tissue death of the heart is avoided. This requires brain death to be the acceptable time to withdraw all life support. Now, DCD can still allow harvesting of the abdominal organs such as the liver, kidneys, and pancreas. However, the heart can only be viable if donation after brain death is acceptable to the family. This also brings to the fore the deeply disturbing thought of practices where inappropriate early assessment of brain death is given, either erroneously or criminally, to allow harvesting of organs for maybe some nefarious purpose. One has to always remember and respect that for one human being to continue to live, another human being has to die in the world of organ donation. There is also the bioethical consideration for living donors, whether one donates to a personal loved relation or to another unrelated human being. There has been the advent of what is called paired exchanges and domino transplants to overcome this issue. In case of liquid cancers, the definitive treatment to some of them is bone marrow or stem cell transplants. The best source of stem cells is embryonic. However, in American and certain other Western nations, conservative politics has made this a major uh, issue, such that the embryonic stem cells are next to impossible to harvest for research or treatment, at least here in America. Therefore, less optimal sources of stem cells have to be used, with often less than optimal results. Finally, the issue of xenographic sources. Xeno means animal, hence animal sources of grafts and transplants constitute special problems which also pose significant concerns. Some of them are being discussed. For, for the first one, let's consider the early aging of grafts. Since animals age at different and often faster rate than humans, their tissues may undergo early aging, which necessitates multiple future surgeries if it is even feasible. The next issue is of xenozoonosis. Now, xenozoonosis is a serious medical concern. It implies diseases that are unique to animals and they jump from animals to humans due to the process of transplants. Such transplants include transplants of heart valves, which can be made uh, from bovine or porcine tissue. And then there is implantation of non-human DNA into humans, which constitutes a permanent alteration of the genetic code, uh, which the implications of which we still do not fully understand. And finally, certain ethical, moral, and societal issues are worthy of consideration. Patients of certain faith may not concede to transplants from animals that they consider unholy or dirty. For example, Jewish people may reject animal source grafts that are considered non-kosher. Muslims may also refuse organs and grafts on similar but not maybe exactly the same issue. These transcend science and should be respected for their own decisions. In expanding the ethical, moral, or societal issues that we have just discussed related to living donors, you need to also consider these additional issues. First of all, for living donors, the decision to donate an organ to someone is fraught with dilemmas. Who should one donate a vital organ, for example, the kidney or their liver to? It does constitute a major health decision for a donor as well. There have been recent instances where donors have died as a result of donating one or part of their organs. Also, the issue of minors being donors because they have their whole lives ahead to live, and should they be donating their vital organs so early in life to older people, however loved? The thought of presumed consent is important. When a person is dying or dead, there is no advocate for them like family. Should it be automatically considered that they have consented for organ donation? What if they had changed their mind even if they had consented long time in the past? How should the health industry proceed? What if a wrong decision is made? For example, harvesting the organs for someone who did not want to consent. The next consideration is, should money be paid to family of deceased for allowing the organs of the dying or dead person to be harvested? What if the family makes a wrong decision to allow early termination of life in greed for money? What are the bioethics for these? Should organs be prioritized based on who has money to pay? What if there is a sicker patient on the waiting list, but a less sicker patient gets the organ because they paid someone to donate? If you remember the late CEO of Apple, Steve Jobs, while Steve Jobs did not bypass prioritization via OPTN, however, when he needed the liver transplant in 2009, he did not wait like others on the long waiting list of Northern California where he lived. Instead, he went to Memphis, Tennessee, where the list was shorter, and it was a strategic move that allowed him to get a liver sooner. This is an example of bioethical dilemma in the world of organ donation. Finally, the issue of forced donation and organ trafficking. Whenever a major commodity such as organs is regulated, there develops a black market in selling and buying such commodity. This black market is fueled by demand and by the mafia operating the business. Underworld involvement leads to instances of forced and illegal donations where people are kidnapped or killed for their organs. You often hear of people who were drugged by their dates and found themselves waking up in hotel bathtubs with massive incisions and bleeding. On investigation, it is found that some of their vital organs, for example the kidneys, were removed. When we attend on patients with this kind of medical issues, we must always keep in mind these bioethical issues in the back of our mind, because while we are advocating for the health of the person in our immediate care, we also should respect how it came to that point. There are many nuances to learning about transplantation science. This is complicated by terminologies that are unique to the organ and the transplant type. In this section, we will discuss some important nuances, beginning with the classification of transplant organs by graft type as determined from an immunologic perspective. We will look at where the organs are placed in the body, look at domino transplants and organ exchanges such as paired exchanges and domino chain exchanges. We will also look at organ retransplantation and organ transplantation in children. Based on immunologic criteria, organs and tissues can be classified into four large types. Let's look at each one of these. Autogenic transplants, also called autografts, homografts, homologous grafts, or autologous grafts. In autogenic transplants, the material for grafting is obtained from the recipient themselves. These are therefore restricted to tissue transplantations only. Allogenic organs are also called allografts, and the process is called allotransplantation. Allotransplants constitute the largest group of organ transplantation. This term refers to organ transplants occurring between genetically dissimilar members of the same species. The donor is matched to the recipient based on their HLA or human leukocyte antigen type. Based on the matching process, one can find four types of transplant. A HLA matched relative is often the first choice. However, this is often not the case because it is hard to come by. The next option is to find an HLA matched but unrelated donor, abbreviated as MUD. If mud donors are not found, then a poor third choice is to find an HLA mismatched family donor. Mismatched HLA organs usually lead to a higher rate of rejection. Finally, a matched but unrelated donor may donate hematopoietic progenitor stem cells from the umbilical cord for liquid transplants. Some common applications of hematopoietic stem cell transplants can be seen in cases like non-Hodgkin's lymphoma, Hodgkin's lymphoma, multiple myeloma, and the leukemias. A subset of allografts is called syngeneic or isografts when the donor is genetically identical to the recipient. This is only feasible in identical twins. Since most people do not have identical twins, most patients do not have this option. However, due to genetically identical state, these patients do not demonstrate the rejection phenomena which makes this type of transplants the most ideal. Xenotransplantation, also called xenografts or heterografts, are organs and tissues being transplanted between two non-identical species. In more simplified terms, this means organs and tissues obtained from animals being transplanted into humans. This is a complex topic all by itself. It leads to mixing of DNA and constitutes severe risks of non-compatibility and transmission of non-human diseases to humans, a process which is called zoonosis. There is more research going on in this field, and some are rather interesting. One of them is to use animals as storage for keeping human organs alive while an ideal transplant candidate is accessed. Based on where an organ is placed inside the body, you will see these two terminologies. An orthotopic transplant, from the Greek word orthos means straight and topos means place, is when organs are placed in their normal position in the body. Examples include the liver and the heart. In heterotopic procedures, the organs are transplanted to a different anatomical location. Examples of heterotopic procedures include the kidneys. Often these kidneys are placed at the bottom of the belly. An interesting heterotopic transplant is also called piggyback transplant, where the original organ is not removed, but the new organ is placed on top of the old organ, and both the organs are connected together to provide simultaneous support to the patient's functions and physiology. These are rare procedures, perhaps once in a lifetime for the physicians and the team taking care of the patient. However, these are feasible, performed, and it is important for professionals in the team to have some idea about these. Kidney transplantation can provide patients of end-stage renal disease with the improved survival and growth potential, as well as elevated quality of life while compared to dialysis. Nevertheless, under the current system, the number of candidates on the waiting list will continue to increase as each year more candidates are added than those that are removed. Therefore, a great deal of strategies have been employed to increase the organ supply and to maximize the utilization of donor grafts. Recently, increasing evidence have supported the effectiveness of recovering and transplanting kidneys from deceased small pediatric donors. indicating a potential approach to expand the donor criteria. Single kidney transplantations, or SKT, and en-bloc kidney transplantation, or EBKT, are two techniques which can be used for kidney transplants. While single kidney transplants can be harvested from adult or pediatric sources, en-bloc kidney transplants are specifically utilized from small pediatric donors into recipients where both kidneys of the pediatric donor is transplanted into the recipient adult. Although there are several unique challenges and complications such as post-transplant vasospasm, which is caused by small renal vessels, and graft failure due to the vascular thrombosis, EBKT is a useful technique to have available. While pediatric donors of up to 20 kilograms body weight can be used for EBKT donation, their supply is relatively much lower than adult donors. However, their utilization greatly increases the available pool of donor organs for kidney transplantation. Overall, single kidney transplantation increases the utilization rate of donor organs. However, en-bloc kidney transplant has been considered to provide a better outcome for the recipients. Due to the shortage of organs, many exchanges have come up where organ supply can be improved. Domino transplants are a type of organ exchange. Once a patient receives an organ, their own underperforming but still working organs can be used, or rather reused, in some or other patient whose organs have completely failed. There are a few different types of domino transplants. Some examples are discussed in the next few slides. Cystic fibrosis patients are good candidates to receive both heart and lung donations together for best outcomes. If they are lucky to receive such a donation, their own heart, if viable, can become a donated organ for someone else. This is the only time a patient may become a living heart donor. Another example of domino transplant is the liver. A patient with end-stage liver disease of some type, for example, familial amyloidotic polyneuropathy, receives a donated liver. Their own liver, while diseased but still functioning, can be retransplanted in an older individual whose lifespan is limited and who needs an urgent liver due to their own liver being far more advanced stage of failure. The advent of increasing ability to obtain grafts from living donors allows the use of paired exchanges. In one example of such a paired exchange, let's see two pairs of donors and recipients. If there is a recipient A who has a committed donor A, quite likely a family member or close friend, and a recipient B with a committed donor, also a friend or family member. Neither recipient A is compatible with donor A, and recipient B is not compatible with his or her committed donor B. However, it may be found that donor B is HLA compatible with recipient A and vice versa. This then sets up a situation where donor A will donate to recipient B and donor B will donate to recipient A in a cross exchange, also called a paired exchange. Another type of organ paired exchange arrangement is called a domino chain paired exchange. With reference to the graphic here, we have one donor each for recipient 1 and 2. There is no donor for recipient 3. However, an altruistic living donor becomes available where someone has come forward to offer an organ which is also not compatible with recipient 3. However, testing shows compatibility of donor 1 to recipient 2 and donor 2 to recipient 3, and the altruistic donor is shown to be compatible with recipient 1. This sets up a domino paired exchange where, despite mutual incompatibility between committed donors to recipients, is overcome by matching to someone else who is compatible, and thereby an organ becomes available to each of the three or more of different recipients in need. These type of domino exchanges require massive coordination, usually available in larger centers with ready-to-transplant teams. When a primary transplant fails for whatever reason, and if the patient is otherwise still a candidate, they will become a consideration for a retransplant procedure. This is an even more complicated situation. When organs are scarce and hardly a primary organ is available, it is often a bigger ethical dilemma whether another organ is even a consideration, with so many other patients waiting on the waiting list for their first organ. Retransplantation is associated with increased mortality and morbidity. It is important to investigate all causes of primary transplant failure to avoid unnecessary risks if a second transplant is even feasible. These qualification criteria are even more stringent, and newer models are being constantly developed to prognosticate outcomes for retransplantation scenarios. This is a brief slide on pediatric transplantations. Children are candidates for both solid as well as liquid transplants. They have the same issues as adults, from organ availability to rejection challenges. While pediatric organs are usually reserved for pediatric patients only, children in need of organs can receive adult donor organs in whole or in part. Their pre and post operative care and rehabilitation considerations are similar. One major challenge seen in pediatric patients is that eventual organ failure in transplanted patients may be related to lack of compliance, especially in some pediatric groups. This lack of compliance will often be the cause of graft failure leading to death. In this section, we will discuss the liquid transplants. Blood is a specialized connective tissue that exists in liquid form. Liquid transplants are type of tissue transplants. They can be blood or blood products, such as packed red blood cells or fresh frozen plasma. Or it can be bone marrow and stem cells harvested from a donor. When the donor is another human being, it is an allogenic transplant, or sometimes the donor is also the recipient themselves, which is known as an autogenic transplant. In autogenic transplants, the recipients will donate their own blood and the healthy cells will be separated. After the preparative process, the same healthy stem cells will be returned to the recipient. This allows for no immune response as the patient is getting back their own cells. However, the autogenic process is not available for every possible situation, which is why the allogenic transplant is required in the other types. Blood transfusions are the commonest type of liquid transplants. It involves transfusing blood obtained from a donor to someone who needs the blood. It is also one of those transplants that does not require the death of the donor. However, blood has to be typed and cross-matched. Typing is the process of determining the blood type, for example, A, B, AB, and O. Along with that, the process of figuring out the RH compatibility, the rhesus factor compatibility, and antibody screen to reduce rejection. Cross-matching is the process of determining if the recipient can safely accept the donated blood even after typing is done. Despite all the precautionary steps taken beforehand, blood transfusions can still cause some complications. These complications are mostly immune system mediated. There can be intravascular hemolysis, which means breakdown of the formed elements of the blood. This can be acute, which is seen within few minutes of transfusion, or can be delayed by hours. A fever can be the only sign of a transfusion reaction when the blood is not appropriate for the patient. In such cases, there may not be true hemolysis, but an inflammatory reaction is triggered, causing the fever. Recipients can bleed into the skin in large splotchy blotches called purpura. There may be immunoglobulin E-mediated allergic reactions or IgA immunoglobulin A-mediated anaphylaxis. There are two lethal disorders that must also be kept in mind in case of blood transfusions. The first one is TRALI, or transfusion-associated lung injury, and the other one is transfusion-associated graft versus host disease, or TAGVHD. While rare, these are lethal diseases. The physical therapist must remember to be observant for variations in vital signs during their interaction after a blood transfusion process has been completed. Blood and stem cell products can be harvested from peripheral blood, umbilical cord, or bone marrow, as has been discussed before. Bone marrow transplant, or BMT, is done for dysfunctional bone marrow as seen in a host of conditions. Examples of some are displayed on the screen. The dysfunctional bone marrow has to be conditioned prior to transplant. That means it undergoes chemotherapy and radiation to weaken or destroy the unhealthy bone marrow and to kill any cancerous cells lingering elsewhere. It is important to have a basic understanding of the process or stages of allogenic hematopoietic stem cell transplant. We will start with the understanding that transplant occurs on date 0. Prior to the transplant, the patient has to undergo preparation. Hence, it is called a preparative regimen. The preparative regimen, also called the conditioning regimen, starts around day 0 minus 5. So that is about 5 days before the actual date of the transplant, and approximately lasts about day 0 minus 1, so up to the day before the actual transplant. So this preparative or conditioning regimen or treatment that I explained in the previous slide is traditionally myeloablative, which means a very high dose, a supralethal dose of total body radiation is combined with chemotherapy agents to kill the body's immune system so that once the transplant occurs, there is no graft rejection, and also to lower the burden of cancer cells in the blood. However, recent knowledge has now allowed a less lethal conditioning regimen to be used. Regardless, physical therapists may first be consulted at this stage. Apart from vigorous strengthening, it is important to have a complete barrier protective clothing to avoid infecting the patient, because their own immune system would have been completely removed. The transplant occurs on day 0 up to day 3. The next 10 to 14 days is the period of recovery as the patient slowly heals and adjusts to the new donated stem cells. This is the period when the body starts showing signs of rejection phenomena known as graft versus host disease. In this condition, the rejection phenomena works a little differently. Whereas in standard rejection phenomena, the host's body rejects the transplanted graft, as in the case of solid organ transplants. However, in GVHD, the graft itself begins to reject the host. This is a dangerous condition requiring additional medications to suppress the immune reaction. This has implications in physical therapy and in strengthening. We will talk about those briefly later on. The graft continues to take hold inside the body. The stage where the graft is able to completely settle in and start supporting the patient's own body systems, it's called engraftment. Engraftment occurs around day 0 plus 10 to up to day 14. So it takes about 2 weeks for the graft to take hold if it is going to really do that. All this time, vigorous PT exercise-based interventions can be used judiciously and combined with mobility training as tolerated, along with the precautions that one must follow. This slide is just a compilation of the indications for bone marrow transplant and in which malignant and non-malignant conditions that it can be used. Organ transplantation is a delicate process and clinically complex with a lot of challenges and pitfalls. Outcomes may vary widely, and despite best care, patients are often lost. However, for those who survive, we still see lots of complications. Also, at initial stages itself, in the acute to post-acute phase, we see complications. Let's look at some of these. To understand complications and conceptualize them better, let us categorize them. There would be thus 5 major categories where complications would arise from. I'm listing them here, and then we will look at each individual one. First, we'll talk about complications related to procurement and surgical procedure. Complications occur right in the beginning, either due to how the organ is procured or problems with the surgical procedure itself. Inadequate screening of organs could lead to the transmission of unknown and sometimes deadly diseases from the donor to the host. Consider the example of a donor having an unknown HIV or hepatitis due to some failure of the screening process beforehand, thus ending up transmitting the disease to the host when the organ is transplanted. While not intentional, Sometimes a failure of surgical procedure can also occur. This can happen either due to poor equipment or inadequate skill, and it may also lead to unforeseen complications that cause complete failure of the graft and eventually herald death. Complications can happen due to transplantation itself. For example, in liquid transplants, the process of myeloablative immunosuppression, which is the first step where the body's immune system is killed off before the transplantation is done, will cause the patient to become susceptible to infections and other complications. Engraftment is a term which signifies that the organ that has been transplanted into the host has settled in and adjusted to the host. Thus, the organ itself may fail to take hold of in the host, and this is known as failure of engraftment. There may be numerous other major or minor issues that may arise from the grafting procedure itself, but the important ones are discussed in here. The immune system leads to one of the most complicated of outcomes following organ transplants and is the basis for much of previous and ongoing research. The immune response results in the rejection phenomena. An intriguing and increasingly understood facet of immune responses is the ability of a recipient to destroy a foreign tissue or organ graft. The phenomena of acute rejection of an allograft involves a series of complex and interrelated cellular and humoral events culminating in graft death. A detailed discussion on rejection of graft is beyond the scope of this presentation. A link has been provided that discusses the biology of acute transplant rejection. A study of this link is recommended for spare reading, but is not necessary for this course. However, some important fundamentals need to be understood. In classic rejection phenomena, the recipient's immune system rejects the transplanted organ, and this is the concern with much of solid organ transplants. However, the rejection phenomena is slightly different in liquid transplants, that is, the hematogenous transplants. See the immune response section after this section for further discussion on this topic. You can use the slide link on this slide number 74 to go to the immune-mediated complications section. In the immune section, you will see a link that will always bring you back to this slide number 74 for continuing with the sequence of the narrative. To do so, you will need the PDF version of this presentation. Complications can occur due to the pharmacologic agents that the patients are put on before and after a transplant. A fuller review of every medication involved in this area is not feasible due to being out of scope for this presentation. However, one needs to understand the role of corticosteroids and their negative and positive effects. One of the biggest challenges in organ transplantation is non-HLA matched donors. This is what leads to the rejection phenomena. This means that the immune system mounts a vigorous attack either on the organ itself or, in some cases that we will discuss, the organ starts attacking the host. This immune response is usually behind most of the failed cases post-transplant. Thus, it makes sense to suppress this immune system in all transplant patients. Whereas there are different categories of drugs to suppress the immune system, the role of corticosteroids in massive quantities cannot be understated. Indeed, corticosteroids in excess of 30 milligrams per day are strongly correlated with the development of some of the most disturbing and undesired side effects in the host patients when it is used over a period lasting weeks. One of these complications is the development of hyperglycemia. Thus, the patient is induced into becoming a diabetic because of the impact of corticosteroids on sugar metabolism. Secondly, there are severe catabolic effects on the muscle due to negative nitrogen balance caused by steroids. This can be usually seen in the rising blood urea nitrogen levels in the blood. Finally, there is complication of severe myopathy triggered by the steroid, which is known as steroid-induced myopathy, that is hard to treat by exercise due to ongoing need for the steroid itself. The nature of this myopathy is proximal at first, that is, the shoulders and the hips are affected early on and then progresses distally. See the comment by Ronan et al. In the slide. There are other undesirable side effects of the steroids other than these and has been discussed in the next slide. Of the other side effects created by the corticosteroids, here is a list. Note how suppression of the immune system adds to the rise of opportunistic infections in these patients. These infections can be life-threatening, including bacterial, viral, fungal, and parasitic. It is not uncommon to get fungal infections of the lungs and the brain. Imagine patients breathing in the same spores that we are all exposed to, and these spores are suppressed by a normal immune system. However, when the immune system is suppressed, the spores grow into fungal hyphae that branch out and form balls of growth in the lungs and the brain, which requires systemic antifungal medications, which have other severe negative side effects, and this becomes a progressive problem. Same is true of other infections as noted. Also note how steroids cause osteoporosis, thus weakens the bones and poses insufficiency fractures. Other drugs may cause many other complications, and thus the side effects are numerous in these patients, and each of these complications require a different type of management. Stop this presentation here and take a more detailed look at least at the listed complications. Recipients or hosts are also susceptible to many psychogenic issues and are beyond the scope of discussion here. However, imagine a patient with a total face transplant completely looking different, which makes for loss of identity or even considering the guilt of the survivor. That is, the host's feelings when they feel that they are able to live due to the sacrifice of someone else's life, which leads to depression among other negative psychogenic effects. See the link for more discussion on this subject. There are some other generic or specific complications that can be seen in specific organ transplants. Some important ones are mentioned here. People undergoing heart transplants require a sternotomy, and precautions associated with that applies. Refer to discussion on sternotomy in cardiopulmonary rehab. The transplanted heart demonstrates chronotropic incompetence. Chronotropic incompetence is broadly defined as the inability of the heart to increase its rate commensurate with increased activity or demand. This is common in patients with cardiovascular disease and produces exercise intolerance, which impairs quality of life and is an independent predictor of major adverse cardiovascular events and overall mortality. Although the intrinsic rate of depolarization of the SA node in the heart is a minimum of 100 per minute, the resting heart rate in humans is generally much lower, which is around 60 to 80 beats per minute, due to the predominating influence of the parasympathetic nervous system via the efferent vagus nerve. However, in transplantation, the vagus nerve is sectioned off and not reconnected at the conclusion of the transplant. Thus, the heart has no parasympathetic regulatory influence and leads to a heart rate that does not follow normal regulatory conventions. A different form of monitoring during exercise has to be used thereby uh, to facilitate activity in these patients. Organ transplantation can lead to transmission of infectious agents, for example, CMV or cytomegalovirus, or hepatitis C, despite all the screening that is usually employed. Bone marrow and hematopoietic stem cell transplants may involve myeloablation, which is a process of killing the recipient's bone marrow to suppress their immune system, and various chemoradiotoxicities due to the ongoing treatment that make a patient particularly sick, and therefore they are not able to participate in rehabilitation measures. Electrolyte imbalances are common in all critical illnesses, and it is true of organ transplant as well. In this section, we will take a 30,000 feet look at the immune response and rejection phenomena, a complex topic all by itself. Unless we have a genetically identical donor and recipient, there exists a genetic disparity between them. This disparity results in the immune system that leads to the acute rejection phenomena. The degree and type of immune response depends on the type of transplant. There are some transplants that are considered immunologically privileged grafts. These transplants do not see an immune response. In the next slide, we'll see some immune-privileged sites where the immune response is not common or it is delayed, if at all. The immune-privileged sites in the body are the hair follicles, the eyes, the testicles, the central nervous system, and the placenta and the fetus. These sites do not show immune response usually. Not all transplant rejection is the same. It can be divided into two major categories distinguished by the mechanism through which it occurs and to a lesser extent by the length of time since the transplant. Acute rejection typically results from immune cells called T cells infiltrating the organ and causing local inflammation that damages the organ. To stave off acute rejection, immunosuppressant drugs are taken. Despite that, if an episode happens anyway, it can be treated with further high doses of steroids. Acute rejection episodes typically occur in the first year after transplant, but if a recipient stops taking the immunosuppressant drugs, they can occur months or even years after the transplant. A particularly severe form of acute rejection is called hyperacute rejection. This is the most dangerous form where an organ may be rejected immediately at the time of surgery or shortly thereafter, and this responds poorly to medical treatment, usually resulting in the death of the patient. Chronic rejection, in contrast, is primarily an antibody-mediated process. During chronic rejection, the person's immune system continually attacks the transplanted organ. Eventually, the damage builds up enough that the organ completely fails. A patient experiencing chronic rejection doesn't display symptoms until the situation is too advanced to do anything about it. There is no treatment for this condition. Biomarkers that indicate how a person's immune system is functioning could help guide medical treatment and the correct dose of immunosuppressants who need those drugs. In the next 5 slides, number 86 to 90, you can see individual discussions on these rejections, including the symptoms and signs of rejection. There is no narration in these next 5 slides. Since you will work with patients after transplant, you need to know what about the clinical manifestations of rejection when they occur. Narration resumes from slide number 91. A particularly vexing rejection phenomena called graft versus host disease, or GVHD, is seen mostly with hematogenous, which is liquid, transplants, including the transfusion of unirradiated blood products. But these can sometimes also occur in solid organ transplants that contain lymphoid tissue. There are 2 types of GVHD, acute and chronic. Acute GVHD involves the skin, liver, and the GI tract. The clinical manifestations include a pruritic or painful rash that starts within a few days of transplant, a generalized itching from initially asymptomatic liver involvement, anorexia, weight loss, and in rare cases followed by hepatic coma. GI involvement causes bloody diarrhea, cramping abdominal pain, and ileus. Chronic GVHD may be an extension of acute GVHD, or it may occur de novo, which means starting from beginning, in patients who never have clinical evidence of prior acute GVHD, or it may emerge after a quiescent interval after acute GVHD has been totally resolved. Manifestations of chronic GVHD affects the eyes, the oral and the GI tract, the lungs, and the neuromuscular tissue. In the eyes, it causes burning, irritation, photophobia, and pain from lack of tear secretion. In the oral and the GI tract, you will see mouth dryness, sensitivity to acidic or spicy foods, dysphagia, odynophagia, which means difficulty swallowing, and insidious weight loss. Pulmonary symptoms include obstructive lung disease with symptoms of wheezing, dyspnea, and chronic cough that is usually non-responsive to bronchodilator therapy. Neuromuscular involvement leads to generalized or focal weakness, neuropathic pain, vision loss, muscle cramps, and myalgias. In the joints, it may cause arthralgia and arthritis. The best strategy to prevent rejection is possibly eHarmony. However, in transplant rejections, some strategies to prevent it is by intense screening of the grafts to find the most compatible tissue where feasible and by aggressive immunosuppression. The most important discovery in the field of immunosuppression was the drug cyclosporin. There are other drugs as well, and we will take a look at that in the pharmacology of transplantation section. A panel reactive antibody, or PRA, refers to a group of antibodies in a test serum that are reactive against any of several known specific antigens in a panel of test cells or purified HLA antigens from cells. It is an immunologic test routinely performed by clinical labs on the blood of people awaiting organ transplantation in an effort to stave off the acute rejection phenomena. Thus, in this test, recipient cells are exposed to random cells of donor population and estimation risks of acute rejection is made. The PRA score is expressed as a percentage between 0 and 100%. It represents the proportion of the population to which the person being tested will react via pre-existing antibodies against the HLA antigens, which include the human leukocyte antigen or HLA and other antigens. A PRA score greater than 6 is in danger, and over 20 require a desensitization process, but its intensity varies. These antibodies target the surface antigens of target cells, such as HLAs. In other words, it is a test of the degree of alloimmunity in a graft recipient, and thus a test that quantifies the risk of transplant rejection. Each population has a different demographic prevalence of particular antigens, so the PRA test panel constituents differ from country to country. In other words, it can be construed that a high PRA value usually means that a particular individual is primed to react immunologically against a large proportion of the population. Individuals with a high PRA value are often called quote unquote sensitized, which indicates that they have been exposed to foreign or non-self proteins in the past and have developed antibodies to them. These antibodies develop following previous transplants, blood transfusions, and pregnancy. Transplanting organs into recipients who are sensitized to the organs significantly increases the risk of acute rejection, resulting in higher immunosuppressant needed and shorter transplant survival within the recipient. People with high PRA scores therefore wait longer for an organ to which they have no pre-existing antibodies. This is one way that the rejection phenomena is managed. The rejection phenomena cannot be totally prevented. Indeed, some amount of immune response is required for complex reasons. However, in those who survive with rejection phenomena, some degree of tolerance will eventually develop. The reasons for this is not fully understood. In this section, we will look at the pharmacology of organ transplant. Drugs are used to address many areas of concern in transplantation. The primary concern area is of rejection, in which immunosuppressants. Secondary concern is that of infections, which are treated by antibiotics. A tertiary concern area is that of other secondary problems that arise, including but not limited to the development of diabetes and anorexia. These are some major drug classes used in immune suppression of transplant patients. Common anti-infectious agents used are shown on the screen. Finally, the prognosis of transplantation is grave. It has been improving steadily, but significant number of deaths persist. Overall, children demonstrate better prognosis than adults. Check out the 5-year survival rates for kidneys, heart, liver, and lungs on this slide.